Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 180. We've just completed another magnificent annual conference, and I'm sure we'll be discussing some parts of it. This morning, we bring to you a truly complex case involving a calcified nodule in the distal left main. Without taking you and discussing more of the specific aspects of this, let me take you to the Cardiac Cath lab where Dr. Sharma and Dr. Kinney are standing by. Anu, Samin, good morning.
Good morning. Good morning, and more important now today is the completion of 15 years of uninterrupted case number 180. Started the journey we started on July 2009. Today become the 15 years, and take us so pride that this really has taken the great educational value globally. Then we'll give a little data next, in the next month that over 25,000 people hitting our webcast every month, in almost all the countries with now 190 plus, and so with India and USA leading. So this is a superb, and we thank our viewership to us to remain on the top. Now with that note, we'll start our just completion, and I wanted to say about completion of our CCC Symposium 2024 at the Marriott Marquis. Very successful, 500 total attendees in person, 184 on the online, 10 live cases done, all with atherectomy. All of them, because theme was bifurcation, calcific lesion. So all of them had imaging, all of them had atherectomy, 8 rota, 2 orbital, and there was 8 IVUS and 2 OCT, all bifurcation cases. So next year also we'll have a separate theme. Maybe we'll have a bifurcation left main only, because in this we had 5 to 6 left main cases. Was superb, and it happened to be on Friday, so we'll repeat the success again on the Friday of next year, which will be June 13th, the Friday the 13th. Let's see. With that note, these are our supporters. As usual, the disclosures, no change. Case number 180, 72-year-old female who presented with dyspnea and found to have severe AS on echo. And then cath revealed 3 vessel and left main disease with the high syntax score. With that age combination was sent for CABG plus surgical valve replacement. Now what we also started adding now is the risk factors. So rather than I write down hypertension, hyperlipidemia, control, non-control, we'll be giving the actual numbers of the A1C, LDL, CRP, and creatinine. So they will be showing that in every case now. Going forward, patient was on aspirin, amlodipine, rosuvastatin, and cath done on March 9th, which revealed subtotal right coronary artery, 99%, you see. But look at the aorta on the right side, very calcified. And then this is the left system, very calcified distal left main, like big nodule going into the circumflex, also lesion in the LAD. And because of that, patient was sent for surgery, as we mentioned. And patient had CABG times 2, LIMA to LAD, RIMA to diagonal. Additional grafts could not be done because of calcified aorta, and patient has a bioprosthetic surgical aortic valve. So did fine initially, then symptoms returned within few weeks, and we felt is likely from residual calcific left main and circ lesion. And today our goal is to that we know the big circ, dominant kind of circ, had a very calcific osteal lesion that we'll do a RotaTripsy of the DES followed by DS of that calcific nodule of the left main as a hybrid strategy. But we saw a little more than that, which Anu will say. Did the angiogram now with the RIMA LIMA, which was just done about 2 months ago.
So Samin, with the protected left main, somewhat with the LIMA to the LAD, the real area of ischemia is emanating from the left circumflex.
Yeah. So we have not done any new, yeah, exactly. Mega circumflex and big calcific nodule. Anu, tell us what you have, the LIMA now.
So LIMA is going to the LAD, which is patent.
It looks good.
Yeah, but then this is where it is nice.
Nice anastomosis, yeah.
But see how the RIMA is. RCA. Oh.
Right remains same, subtotal.
So RIMA has a significant lesion.
It is
Distal
supposed to go to the
anastomosis.
diagonal.
Yeah.
The
Supposed to
distal
go
is
to
like almost
diagonal.
subtotal.
Yeah.
No, but is it because of comparative flow, you think, or
No, no, no.
anastomotic?
No,
Yeah,
here,
another better
it's
picture, or this is
anastomotic
it?
picture. This is what it is because her aorta is very tortuous. It's not that easy. So I
Yeah.
think if you need more selective, we may have to go radial, right radial.
Anu, I'm sure this was a very challenging surgery, yet a lot could be desired here in the way the patient has been
Yeah, this is a very good
recanalized.
picture. Yeah.
Very, yeah, lovely picture. See
Yeah.
it, but a lot
But
of
I mean,
challenges there.
ideally,
Yeah,
I mean, ideally should not happen. In 2 months, this should not
Yeah.
have happened.
No, it
right,
should not
Yeah.
happen.
Get the rotor ready. Yeah.
No, I want to image first.
Yeah, that's fine.
Get the IVUS. Yeah.
1.75. So we actually
17520. I think 20 could
one
be okay.
single bar.
Yes.
Okay. The 2
But
bar.
I want to image before we do that. Let me see. So this is where we are. This was, let me show you.
No,
Anu,
2 things.
seven French guide.
Yeah.
Yes.
Okay.
Okay. No, but my question is, can we take a good epicranial picture that is diagonal
later,
okay?
if this
No,
is okay.
no. Question is the diagonal all right? So therefore, then you don't ignore the RIMA at all. If the diagonal is okay, once you do the left main here, we don't
Yeah,
need
let's
to worry about
open
the
the
diagonal.
left main and we'll
We do it
a
in the
picture
end.
later.
Okay,
Yeah,
fine.
at the end.
Okay, so the rota wire has been advanced.
So let us, this is where the angiogram is. Yes.
Discuss the angiogram. Very calcific nodule.
Calcific, no, I mean, I would say calcific distal left main involving both ostial circ and ostial LAD. See there? A lot of calcium. We wired with a fielder wire, and you can see large curve in the fielder to get into the circumflex. Kept going to the ramus, so pull back, and then able to navigate into the circumflex.
Samin,
So this
although
is this wiring action is the one that's going to tell us also, and then the microcatheter, which is a fine cross, what should be the burst size. So fine cross wire was okay, and then even the fine cross we were able to get through the lesion. Let's IVUS. So the question is 175 or 20 bar. It's a short lesion. I think 20 bar should be okay here.
Yeah, so actually in the room, we have our usual players and nurses with Will and Ashley, and Tak, Asif and Habib. There is a big change on the imaging. Our usual Kiski is gone, and now
No, do not. It's the wrong
no,
word.
gone means
Yeah,
okay.
he's
Gone means
on
he's
vacation.
gone to Japan to take care of the family issues. That's what it means. Not that he has gone far away. So it just means he's off now because of he has to take care of the family issues and will be back in end of July. And Julia, who are also the part our imaging the lab has been part of the many our imaging trials. She'll be on the we'll hear from her interpretation of this very calcific, which looks like nodule, but I think imaging will tell us where exactly we are.
Okay, give us IVUS.
All right, Julia, all ready? Louder. Yeah, good. Yeah.
Let's show Yulia.
Yeah.
Yulia actually is the director of our imaging core
And
lab.
show her also her face.
Yeah. And the main player for our yellow trial. Of course,
Yulia,
Kiski did most of the imaging with me in the lab, but she was the core lab director analyzing in the core lab. So that's one. I also have to tell you something that now we have observers coming from all over the world asking they want a fellowship short observer 1 week, couple of weeks just with Kiski to learn imaging.
Yeah.
not at all surprising. Not at all surprising. Yulia, so nice to have you today live. You've been such a wonderful, quiet performer behind the scenes for decades here.
Okay, we can do the IVUS.
Okay, put the IVUS on the main. We have it here, 3.5.
Recording?
Good. Okay. You
Ready?
start.
Start.
No, get a 3.5.
Okay, that's where it is.
Such a large vessel.
Yeah.
So give us the diameter. I think
4.5.
Yeah, 3.5 and
yeah,
3.5 score
it's
flat.
diameter is like a 1.6. Let's do 2.
2. Good. Get a 2 bar ready.
I mean, if somebody says 175 bar is okay too, since it's a short lesion and 360-degree calcium with a large nodule. You see there? Yeah, right there. This we will call it as a massive nodule, more than 90 degree. The nodule, the base of the nodule is more than 90 degrees, so we will call it as a massive nodule.
So, Samin, purely for discussion point of view, I'm sure this is right on top of the minds of people watching us. Would you have considered, or should one even consider IVL?
So no, I think in this kind of a large vessel, rota alone is not enough, and you may need a second plaque modification device. So actually, there is a trial to answer that question, randomized trial. I'll show the data today. But key is that not every case you need that. But when you go IVL directly, I think this case probably with a little balloon dilatation, IVL will go. Because it's a short proximal lesion, and you saw the IVAS went very easy. So IVL could be the one strategy. But we still look at the calcific nodule. So I think this is the kind of case you have to do combined strategy, and that's what our goal is. We want to make it a RotaTripsy. So after that we'll have it's a 3.5 or 4 vessel.
1, 2,
IVL
4. It's
4.
a 4 vessel,
So,
and then go back, Yulia, to show us that whole 360-degree calcium. So at the level of the nodule, you see that there is no calcium around the vessel.
Only two
And
quadrants.
then, right?
2 quadrants here.
Yeah, and then
Then
come back,
small.
yeah, come back a little bit. That's okay. That's left
That's
main.
it. Yeah.
Where's that 360-degree
No,
calcium?
there's. I don't think there is 360.
No.
No.
Okay, pull back
It's
again.
2
Put
quadrants.
this-
Look, okay. That's the largest. Yeah.
Largest. Okay, come back again a
the
little bit.
180.
Yeah, right there, right there.
Yeah.
You start seeing some calcium.
Oh, but
Yeah,
Like 270. They're
no,
not a 360 there yet, 270.
90
Yeah,
degree.
yeah.
Yeah.
Even a little more.
maybe. Yeah.
Come back a little bit more, just a little bit more. You see a little more. Yeah.
Here.
Some more. Yes. 360. I saw a 360 ring, very short,
Ring. Well,
of the left main.
no, this.
Oh, there.
No, by
So
the time
that
this
is,
is the
hold
guide
on.
catheter.
No, this is
No,
not the
that is
vessel.
guide.
No, this
Yeah.
is the end of the
Yeah,
vessel.
that's
right
the guide.
here. Yeah.
Yeah, that's the guide catheter.
Yeah.
is
So
So it's a
I say-
270 degree calcium
No,
with a large.
actually less than 90 degree. Large nodule with not a lot of calcium around the nodule. See that?
But protruding right there, like that. Yeah.
protruding
That's-
calcium.
You have to
Yeah.
cut this. Yeah.
Okay.
So this, I think, based on what our
give us the score flex.
experience is, ideal case for rota, not so much for IVL, because there's not calcium on the rest, though they will say that the sound wave will not penetrate non-calcified area. Though this is actually a lot of discussion, which is the right treatment when you have a nodule.
And some coming back to the point of the nodule, I think the real challenge still remain. Is orbital atherectomy shaves it better than rotational? That I think idea that controversy will, because there is no data to support one versus the other. Some people believe that orbital will be better in the nodules, really shaving it.
Go. Okay. Ready?
Yeah. But yeah, if somebody wants to just IVL, that's okay too. This case, I would say that it's a good case for IVL alone also. But you know, the guide chance with the rota is that it is just combining two technology and get the best results, because there is a lot of calcium. This patient already have a CABG. We want to get a best result possible. They're too far.
So now I will start it from the guide. Okay.
Yeah.
Yes.
Too
Is
far.
that-
No. Guide out and a little bit too far. Yeah. Good.
It's okay. Okay.
Yep.
Now I want to be coaxial. Yes. Good. So we'll do a 3-step in the guide. ostial disease, which is ostial left main, ostial RCA, many times you'll start burring from the guide.
Good.
Okay,
That's
off.
Good.
So I'll pull the guide back again.
Yeah. And this may cause some asystole. Pull back. Asystole.
Oh.
Yeah. Okay. Give atropine. So this we are going to give atropine and
Said,
aminophylline.
yeah. The reason is a diseased RCA, probably a codominant, codominant circ.
So two things you can do. You can put a temporary pacemaker, or let's give a combination of aminophylline and atropine and see
We
if
have
that works out. Yeah.
give me a pacer. That's
No,
one.
but let's try. Let's teach people that if we can work it out, fine. Otherwise,
Other reason also it's a big burr. Smaller burr would have been okay. A bigger burr in the left vein is causing
done both aminophylline given, right?
Okay, we'll try. Otherwise, be ready with the pacer. Again, the question was, should we have gone with a floppy wire or?
Yeah. Pacemaker. Get a pacemaker.
Yeah. I think let's do pacemaker.
So this is the one you need a pacemaker. Yeah.
I think we should have gone 175 bar.
Yeah.
Okay.
Before I was saying that word, it became asystole. I was saying that we might develop a bradycardia and asystole, and exactly that happened. And we have seen that in some of the unprotected left main. This is all the protected left main. Yeah, you have it. What do you need?
No, it's a big bar SS. That's the one that's doing it. No, I want something to make a curve.
No, we should take that. No, we always use this.
Give that.
Yeah, that's what I'm saying. We always use this.
How can you give me this? I will attach. All right. Always keep it.
And I would also say for operators, this was because if we are going to use a 3.5 or 4 IVL, make sure IVL should be ready also. That it's okay to use a 1.75 because whole goal with the atherectomy now is that how can we do it with the least complication and least disturbance. And I think the 1.75 would have been that answer towards that. Your body is still too far occlusive, I think.
No, it's okay.
Okay.
Ready? Okay, deflate.
And this 4 French are a little flimsy, but I can tell you advantage over
French,
probably 300,000 pacemaker. We have zero perforation, zero with the pacemaker.
Okay, let me leave it at the.
Okay. Only one time we had during COVID when 4 French was not available. It was 5 French stiff. They have one perforation. But 4 French pacemaker, I've been doing it for the last 25 years. So many, and we have zero perforation with that 4 French balloon tip.
Okay, try the pacer. It's not in the apex, but RVOT.
That's okay.
So, I mean, several questions have been coming through. One of the relevant ones
I have
is,
a 175 bar also ready. Yeah.
Can we suspect aspirin resistance here?
Okay, we can test it before the VR end. We can do. Patient
good.
was on only aspirin, was not on
70.
clopidogrel before, right? Yeah. So we'll give the aspirin. It's a 550. Good.
Another question is, how would your strategy change if IVUS showed calcium in adventitia only?
Yeah. So that basically means that it's a superficial calcium. The question comes is which technique better? So I would say that atherectomy will not be that, which happens in 10-12% of cases. IVL probably will work in both type of calcium.
Several people, Samin, have observed and commented.
Good.
What made you predict that there would be a systole?
Oh, because of the left main and the burr totally obstructing the...
No. I'm going to do one more.
Sorry. Okay. The totally, because once you have a total cessation of the blood flow, like RCA is already subtotal, and you knew that this burr 2O is going to jam into the lesion, and that's not a truly visual gyrus reflex, but we have seen with the left main. just by personal experience. The many of these cases we have
In the
seen.
indication for a pacer, we always say elderly patient with left main, always have it, and women.
And
Yeah,
particularly if there is RC is compromised.
yeah.
That we have seen very often. Not uncommon.
So next month, oh, okay.
We can have the lights down a little bit or no?
I mean, although
Take it
the
out.
thrust of improvement here is going to be for the very large left circumflex territory,
Yeah.
yet you will also improve the flow in the LAD.
Oh, no. Because of that left main, patient went for CABG and they put a LIMA and diagonal graft only. I thought that they should have done one graft into the circumflex and not the diagonal.
No, the
that would have been, yeah.
patient
Well,
also
the-
had aorta that was.
Yeah. No, I know, but I'm saying
Calcified.
second graft
Yes.
should have gone to the circumflex. That's what I'm
Very large
saying. Yeah.
But
yeah.
then the question also is that if there is going to be more flow in the LAD, are you concerned about the competitive flow to the LIMA?
Yeah, that's always the question remains. That's a tough one.
So
But
we will leave the proximal LAD disease.
Right, exactly.
But do you want to leave
but-
it?
Can leave it.
The guy, the RIMA is gone. We will require another intervention otherwise. If
What
you can
was-
open the
Right.
left main and there's a good, there was no disease in the diagonal. It was done only because of the left main. There was moderate disease there.
Yeah, so then we don't do anything. Means leave it.
Okay.
because-
Get the IVL ready. 3.5.
I saw her in the office for tower evaluation.
4.0.
Some dampening of pressure there.
Yeah. So we're just going to take that out.
Let's.
once-
No. I
yeah.
want to IVUS again.
Yeah.
Get the IVUS.
Well, the vessel is definitely looking much better, and
Get ready.
yes, imaging will be a very good idea here.
No, just to see what our nodule. What did the bird do to the nodule?
Yeah. Take this out. Ready? Rota
And of
out.
course-
Yeah. And the question comes is which, and I'll show you the technique, the which does which of those three, IVL, laser or RA cause more calcium fractures. So it turns out to be, if you're taking a fracture, not the debulking, not the shaving, but the fracture point of view, IVL does a better job than any of these techniques.
Right. So an entire discussion group here has emerged, and people themselves have answered about the need and not the need for a pacemaker. It's
Okay, start the image.
Dr.
IVUS
Gopi
again.
Krishnan,
Yes.
Dr. Nikhil
Ready?
Jha, and of course all of them have inferred that the pacemaker is needed.
Yeah. No, but I mean, we showed it. We did everything possible. Guide out, a big bar, give aminophylline, atropine. Still, we saw the asystole.
Go back.
So we,
There,
I mean,
at
this
the level of
case
the nodule.
originally may not have been, but during the procedure, now, then you don't need to be bullish. Once you saw, by your technique, become asystole, because asystole, what we do, will start the slow flow. You don't want that, because that will ultimately affect your results.
So we see the little.
The shape is different here,
Ablation, right?
Yeah,
At
the
the-
shape is different. There is some fracture here.
No, but tell us the height of or the thickness of the calcific nodule earlier versus now.
No.
Good, IVL now. Now you see the IVL, 4.0 ready.
Yeah.
Anybody asking the question? Should we do IVL or just dilate?
More are tending towards IVL, and somebody has also asked. I've kind of forgotten what was there in Samin's first slide. That did the patient have a stress test?
No,
No.
the patient never, because patient did not have a stress test. It was patient actually was
planned,
referred for
yeah.
the patient came for aortic stenosis
Evaluation of tower. She was all booked for tower, and
Yeah.
when we saw, is one of the indication of a SAVR in this day and age is age where patient will tolerate surgery, and then significant CAD, which she
So
will
in
have
this
had.
particular case, yeah. So coming back to the point, I would say that even by the OC criteria, once you have an angiographic lesion of 90% in the valve disease patient, you don't need to do any stress test. And this case has an indication for surgery. Now surgery could not be done, so we are doing the hybrid intervention. Go forth. Yeah. So that's the key. So this case would not require a stress test in between. So we have 4 atmosphere with the 4 IVL. There is still a big dent there.
Yeah, at the more in the inferior part.
Yeah.
And
But
let's
you
see
guys,
how that
these guys
responds.
do not inflate and wait before you
No, we always
come
do.
down.
Hold it now. Okay, so we are going now. It's a good size, so we go to 6 atmosphere.
It's
Now go.
open more.
Yep, yep.
And opened almost completely now.
Mm,
Slight indentation, slight
yeah,
at the
slight.
inferior part, which is
Okay, 8. No. Okay, let's go one more. I think we want to change the position a little bit.
No. This nodule only at a short.
Go.
almost open completely.
Yeah, now definitely, yeah. And remember, circumflex, no matter what it is, you'll always have a 5-10% dent, even with the best of debulking, plaque modification, and stenting.
IVUS again.
Yes, this IVUS run, I think, will be very revealing, and I think we'll have abundant fractures there.
Good.
Anu, a very relevant question for you. In case of larger bird, you utilize low speed of 140 to decrease platelet activation and no reflow.
Yeah. I mean, 150 is ideal. You don't need to go lower than that.
Yeah.
So then the ablation speed, if you go down, ablation will not happen. So you saw, as long as we know that we are doing at the right technique, we'll be okay.
But I think this is again Dr. Mahmoud Al Rais who had asked this. His thinking is right. I think that you're not going to be going at 180 for
yeah.
Exactly.
So
right.
140 or 150, although the one of the randomized trial of 100 patients from Japan did not have any difference in the slow flow and CK release, but I think in a severely calcific vessels, large vessels like this, the lower speed of 140, 150 will give rise to less platelet aggregation. Actually, I felt that back in 1998, and we did the experiment, 180, 140, and we found less platelet activation as 140.
Yes, go back. Nothing.
Okay.
I don't see any change.
No, where change? I think multiple cuts.
There are cuts.
Yeah.
There are cuts.
Look at that.
That was uniform.
Yeah, they were not there before.
Yeah. And the luminous, you see that?
Yeah.
That was one smooth.
Unless you have randomized trial, you will never say this could have happened even with a large cutting balloon.
No, but I'll show you the randomized trial. We'll show the data of the randomized now.
Where you have with the cutting balloon versus IVL.
Yeah, no, not cutting balloon, but the rotablation, laser. We didn't use the cutting balloon.
No, here I'm saying once you do and done atherectomy.
Yeah, there are cutting balloon trial also. No, cutting balloon comparing IVL. So there are all the trials there. But today what we are going to show is.
Anu, can you take 1 or 2 cc quick injection so that
we're going to show you an angio now.
Of course.
No, we don't need an NC balloon now. We can just stent it.
No, not yet. Now, if you want to see it, let's do the score flex and see now with a scoring balloon. Yeah, but LED. Look at the LED is gone. Okay, so I would say that there is no reason for us, even if there is a small vessels coming out from the LED, little septal, little ramus, I think we should keep them. So put a wire into the septal and then dilate with that 3.5, or we can use the score flex, we have it there in that direction. Here. So we restore. It's a score flex, 3.5.
For what?
So going into the LED, that exactly was for the LED. And it will do little work in the left main also. And if you want to do and see more cuts, whether adding the score flex or, both the cutting balloon and scoring balloons will give additional cuts after the IVL and rota. If you want to do another imaging, will be okay. Good. So this techniques of plaque modification done the tremendous job in the left main and the circ, and they still the plaque push out into the circumflex area. I mean to the LED area. So what you could
LED,
do,
yeah.
put this wire back into the circ and take the circ, our circ wire, that will go to the LED better. Need a little strength. Although the guide may be a little too not your friend right now.
Select selectively
Yeah.
into the circ.
Yeah. Yeah, I think this will be
I
better.
mean, another question that how much is the concern with these calcific nodules with or without atherectomy about perforation?
Yeah, so that's a very good point. So I think a lot of people believe there is no difference in the calcific and non-calcific nodule outcomes after, but I can tell you the majority of the perforation we have are with the calcific nodule. Because one of the reason is, one, the normal segment of the vessel wall will expand after the atherectomy with the balloon dilatation. And the secondly, calcium nodule itself can be pushed through the adventitia and cause the perforation. So when we see perforation, with the atherectomy, it's usually after, not during the procedure. During the procedure is that you have cut the calcium. But after the procedure with the balloon dilatation, it happens because of the this calcific nodule in which the normal segment is pushed out or the nodule itself is pushed out into the wall.
Get me a 2O12 balloon.
Okay,
So
2O12, you had the balloon, right? Yeah.
Like
Similar
this, this imaging where you have only the nodule, you didn't have circumferential calcium, there was a risk of perforation.
right.
Here, if you have circumferential calcium, the risk of perforation is slightly lower because the so-called normal looking vessel on the opposite wall.
Questions have also come regarding cutting balloon use here.
I mean, Wolverine.
Yeah,
Let's
right.
be
Yeah.
clear, Wolverine, yes.
Yeah, prepare calc, trial, they use both scoring and the cutting balloon both. And they both were okay. No much difference whether you're scoring. Scoring actually made a little advantage sometimes that you can go to a non-compliant balloon, you can go to very high pressure.
So, I mean, I'm trying to, several questions have come on this. I'm trying to summarize the sentiment that, you know, angiographically, there was clearly expansion with the IVL. Why did we not see that with imaging? I mean,
Let's find out.
No, I think the large nodule, I know though the surface of the nodule has atherectomy has done something, somehow as soon as it just prolapses again.
No, but did the lumen at the site of the calcific nodule changed after the IVL? That's the question.
I'm checking 1 second.
And to me, it looks like keep showing the
To
IVL.
some extent.
Keep showing that I was on one side also. Yeah, good.
So this will, as soon as you stent, you will see a big difference.
Yeah,
It
there
needs a
was
stent
a
to
large increase in lumen
Yeah.
from 3.5 to almost 6.
No, it definitely improved.
Yeah, yeah.
So Samir, clearly, there's no question on that point. Now you can use the Corsair.
I am sure this is hugely satisfying
Yeah.
to the numerous people who
Yeah.
asked this.
Yeah.
No, the problem is the guide is a trouble. Why
Not
don't we
venture.
just take care of the circumflex and then we do it later? Or you have to change the guide.
Want to thank
Guide
our
is,
audience
sick.
one more time of keeping it so interactive. You know, there is a flurry of questions, observations, recommendations on everything we've been doing here. And I know Dr. Sharma would be covering some of the
Guide, push.
Cannot.
Let's
It
point
is
out.
when you push it is into
Yeah.
the LED. Cannot.
Yeah, good. Yeah. So
It
now,
Some
will
of
not
the-
because it's on the superior surface.
right now. Yeah.
data about the 15 years, but I can tell you the far significantly increased participation, how we have maintained it to be much more interactive has been, I think that considerably adds
What
to
size
the
guide is this?
Okay.
to the
Now
educational value.
Yeah, absolutely.
Okay, let's
More
stent across,
importantly,
and then we can
starting
cross.
next month, we are adding, always we keep doing new things. We are adding the CME component to the live transmission. So that will be that there will be a QR code in the beginning. Then there will be a 2-hour CME credit. Tell us what you want now.
No, we'll stent across in the circ. Then
Okay.
we can intervene, or we have to change the guide to VL30.
Yeah. Yeah. Okay. Well, tell us what you want to do now.
Let's stent
Which
the
is sent.
circle.
Okay. Yes.
4-0, right? And then
Yeah.
we have to post it.
Yeah. 4012.
16.
And you've decided to leave the
4-0,
LED alone.
16.
4016.
No, we have to change the guide. It's a short left main. It's a large VL35. It's just getting into the circ. It is the superior surface of the left main. I have to go to VL30. Yeah.
To
This was
guide towards
3.5.
LED.
This is a 3.5. Yeah. To get into the LED.
Okay.
Yeah.
So we're doing a Giants Megatron. What do you want to do?
No, let's go to 4-0, 16. You have Promus? Okay.
Take this wire out.
Leave it out. And get me a VL30 guide also once we stent, if you have to change into the.
Samin, this is
Okay.
we've
That's
often
okay. Till it's coming. Yeah.
we've often discussed about it, and I know you have had several publications to this effect, but Dr. Nikhilja has mentioned, and I don't think he's just trying to flatter you. There is I think some thought process behind it. Dr. Sharma, please write a book on tips and tricks in complex PCI for young cardiologists. Your experience is valuable.
Yeah. So we actually have our
Have the book, yeah.
No, but we have the interventional, the book which we had wrote down is special, all the aspects of the technique. We have, done as much as possible, and we continue to teach people. And we are putting a 4-0. We got the stent or no? Yeah. So either you need some support, but without that, this wire is not going to go.
Anu, a comment for you. You could use a dual lumen microcatheter for the
That's a lot of
circ
people
wire.
want. Yeah. You want
Make
to
it
try that?
more.
Because a lot of discussion happened at that time also.
No, I'm not trying
Huh?
it.
Yeah,
No.
yeah. Already complex enough.
Yeah, so a lot of people use that. There was a lot of discussion. I mean, that's not have been our practice, but a lot of people will use. This is the 4016 Promus. Huh? The Synergy XD.
No, please.
Huh?
What is that? Okay, what's the size? 4-0? 16, yeah.
Okay. So 4016.
If you understand why we are not able to go to circumflex, I think then we can know this double lumen catheter is not going to help us there. So the guide is going into the
work against
circumflex.
you. Yeah,
Yes.
it will work totally against you here.
Yes, it's not a question of
And
just use
not
this,
only
use that.
No, but
it
we can
could
try
be
that today.
harmful too.
No,
Yes.
no, will not be harmful because your left main and circ is very
protected.
stable. Yeah. So this is, no, if you want, people are asking, we can try. Let's show them whether it will work or not. Give the catheter. Yeah, let's
No, they
try.
want to
One second.
learn from us to understand how to work it, or
I
we
know,
going
but,
to.
no, but okay. Twin pass. Give twin pass 1 minute. Yeah.
You need a VL guide, a shorter guide that will sit in the left main. If you see the first picture, right? And then we will be able to get into the LAD.
Right.
So, but this is the case where the whole question is to get to the side branch. There are a lot of papers on then, case reports have come out. They're using the twin pass, and there are 3 catheters now. Eggshell, there's few names with the same concept. Go.
No, you have to put the wire, no?
No, I know,
The
but
side
will
branch,
once you
yes.
bring it, no. Go on this wire, your wire. Yeah, good. And get a filter wire. We have it. Yeah, good. We have it. As long as it's good, not destroyed. New filter wire. Good. That's magnify. Yeah. Will be coming out now.
No, long way.
Good. So pull back a little more.
Pull the guide
Good.
back.
Yeah, here.
Other thing is maybe I need a miracle.
And you pointed out also, we don't use this, but you know, a lot of people wanted to say, but to us, the more difficult because what we use is the angulated catheter. We'll use a
Yeah,
venture or
if somebody told you use a venture or a supercross, maybe, but this is not going to help out.
But here your challenge is more the guiding catheter
Yes,
also, no?
yes,
Yeah.
yes, yes. Get me a venture. So what's that? But then even if we cross, we cannot jail it.
No,
This
we just
one.
open and then we just open and
Then
come out.
this.
Yeah.
Okay, get us a no 3 because you need a you have a miracle 3.
Because not only that, to make complexity, once you put it, then you have to still exchange or trap, and then wires comes out. So all those things are there. So us very angulated. To me, using the venture, initially they thought the venture will go out, but venture has been taken up, and they will continue to make it. And then otherwise, you can use Supercross 120, which will take few seconds and go in. But we are just going through this exercise. Clearly, that it's of a doubtful benefit. But I think we keep the vessel open is our always a goal. We don't want to close the vessels. The question is, you need to go a little more with the catheter.
Okay, can you give me a VL guide?
No,
Yes.
but if you need the venture,
No, I'll tell you. VL 3.
this is the Miracle 3. Go a little more in the catheter. So it opens up, comes out at that level. Advance the
Hold on.
catheter a little more at the LED level.
I maybe okay. Some die. No, somewhere else. Okay, you have the VL 3. Some die. We should be able to. Now get the VL 3 guide. And then keep the miracle, okay?
So we're changing the guide, knowing that the guide was selectively going into the circ. In order to go into the LAD, we're going with the 3O guide now.
Okay, now get us the run through to get into the circumflex, right?
Do you want to go with, okay, this is the run through straight tip. Okay.
Okay, fine cross. Give me the fine cross. No, I
Good,
just
good.
want to put this in the circumflex.
Yeah.
That's it.
Your circ we have to protect. So we are protecting the circumflex.
Another very interesting comment. Could you inflate balloon in the left circumflex as deflection
That I
balloon
can
for
tell
the
you,
wire?
that never works. That I agree will never work. We have tried at least in my lifetime 25 times and n equal to 0 success. And one time we actually have it, but Columbus had, he had it also like 20 times and n equal to 0 in these tough cases. Good. So
Okay,
let's go
take a
to,
picture now.
okay. Good. Good.
Okay.
Yeah.
Better shot at the LAD.
This is the field refine cross, and then you can put your Corsair.
Yes,
your
no,
Miracle 3.
Miracle 6, so go down. Just want to see that it is nice and sitting, yeah. So now, go magnify and a better picture.
Circumflex is looking very good.
Yeah.
Probably
Yes,
could even
yes.
use the 4-5.
Okay, yeah.
Yeah, 4
Good,
will be
good.
okay. Good. So this
You
is
have a
the
nice
fielder.
curve.
Yeah, yeah. Your fielder is okay. Then
Fielder
we have your,
itself may go. Now that you have the guide that's facing just in the left main, it's nice and coaxial. We should have access into the LAD. Okay, good. And you have the Miracle ready for me, the same wire. You may need a stiffer wire here. That is Miracle.
There is a chorus of people saying
Yeah.
focus on the circumflex only.
I know. They're telling us now after half hour of this. Ay. No, that
Okay,
exactly
now
what
some
the,
dye.
yeah, way too proximal. You have to
Yes.
pull back the guide a little more.
No. I think you know what?
Origin is at the tip of the guide on the top. Yeah, this is the one.
Okay. What was the one that I said we should do,
guide.
and how long did it take? Go,
Yep.
take a picture.
Okay. Yeah. So this way we got our RIMAs back. We got this. Now you want. No, we can take the core flux. You want action length run through?
Yeah.
What do you want now? Or we can take
You
this
run
out.
through. Accent and run through. Which one?
No, I can take this out with my wire technique. Go fluoro. Yeah. Get the deflator. The same we'll try to see if it comes out. Many times it does. Basically we are attaching the deflator to our and this one was
Usually you go
no,
with
I
the
know,
syringe.
one by one. So this was a fine cross.
Yes.
Right? Good. Fluoro. Yeah, go. Keep going. Good.
But Samir, you see that what actually made our issue was the guide was too deep in the circumflex.
Absolutely.
You just needed a short guide to sit in the left main, and then the wire will get into the LAD.
Absolutely. Completely
So
agree.
you needed the tips and tricks, and that's the tips and tricks you learn.
Good. So, okay, so we now have a 3.5 score flex going into the left main to the LAD. Another
You saw
non-compliant
it
balloon.
probably took us 10 seconds to cross.
Yeah.
Okay, then what size you want? The
You
stent?
have 4. We already have the stent. The stent has been opened. Good.
Up.
Go up.
No, that's a balloon, small balloon into the.
No, it's a 4 score
Down.
flex.
Okay.
Yeah, 4. Direct, because this one we knew we'll be able to get through. Yeah, just come to ostium, the LED. Yeah, good. Go up here.
Okay, get the stent. The only question is we have a 4-0 right down. Then we post
So
dilate.
what you do is, while you're putting a stent, I'll just start doing some of my discussion, and then you'll show once we have the optimization
this.
with your post.
So just
Dilatation,
just to quickly complete the discussion, all of them are, and one of the focus discussion is the plan is to be using a mini crusher.
No, we are just going to stent into the circumflex, no?
Yeah.
No.
The goal here was
Stent
just to,
across.
but don't occlude the vessel. Keep it open. That's what we did. So I don't think we should put a mini crush here.
Yeah, then that LIMA definitely
Lima
will.
be.
Then you'll be trouble of both LIMA and diagonal. Okay. So with that note, while they are getting this, let's go about 10-12% till optimizing. So clearly everybody agrees now. We got a nice lumen in the ostial LED. It's open. It was significant disease. We keep it open, and stent will be placed with a little pot and post dilatation, and we'll come back with the imaging later in about 10 minutes. Okay. With that note, we go to our presentation. Basically, issues are one, trial from EuroPCR of this year, Callisto trial, roller coaster Epic 22, BioAscent ISR, and the cost effectiveness of PCI versus CABG in FAME3 trial at 3 years. Then we have very nice focus review of the month. It's like a strategy of Mount Sinai, what we have been doing for last more than 10-12 years. That is outcome of PCI in multivessel disease patients who decline CABG. So key is the patient PCI who multivessel CAD who were recommended for but decline CABG, publication in American Heart Association.
Balloon.
So therefore, first one was Calypso trial. It was a OCT versus angiography guidance for the calcific lesion done in France, and basically was the primary endpoint post PCI, MSA and other points, and basically was that we have calcium arc of 180, 180, 270 and more than 270. They have clear-cut protocol how to take care of the calcific lesion. Very nice this description, and what they found in about 150 patients overall. You can see here the use of individual additional upfront lesion preparation. IVL was used more in the OCT guidance compared to rotablation, little more in the angio guidance. And what the results? MSA significantly better after the OCT guidance compared to angio guidance, 6.9 versus 5.3 as you see here. Now other endpoints, measure malapposition stent percentage was lower in the OCT guidance compared to angio guidance, and stent cross average stent area was also significant and better expansion which we saw with the OCT versus angio. So, and there is no difference in terms of other endpoints of the perforations, and periprostheal MI was identical. So key was that Callisto trial in the calcific lesion, we have another device, another data to say OCT was better compared to angio guiding. Now then, comparison which we have discussed today, RA, lithotripsy, IVL or laser, we call ELCA, in calcific lesion, which is roller coaster Epic 22 trial, 3 devices, all can be used, and a primary endpoint was % of stent expansion by OCT. So OCT is like becoming a big player in these the trials. So what they have a clear-cut plan. After randomization, if you need a second plaque modification technique, then you go to the other divide based on the uncrossable or undilatable, and of course in the final you have a stent expansion. So overall comparative data were equal. The 3 techniques were shown. Okay, but look at this now. The undilatable in the rota group are 6 patients. So I don't understand that part. And they of course have to use a laser in one case and 3 use IVL. Then success was of course 100% in all of them. In case of you started with the IVL, then there were 4 uncrossable and 2 undilatable, which is requiring rota and ELCA in 3 each. And then in the ELCA group, 8 were 6 uncrossable, 2 undilatable, and then use a majority being the rotational atherectomy as a second plaque modification device. So what they did, calcium fracture. You can see here identical with the 3 techniques, 66, 77, 66.7. Although you can see numerically higher calcium fracture we saw with the IVL. Although the stent, minimal stent area was identical in 3 groups as shown here. Little higher, I would say, with the rotational atherectomy. So intensity to treat, RA better than new techniques, little better, comes up in terms of better stent expansion and MSA with the RA compared to other techniques, which shown here. And so basically this is the device technique where it shows low complication, similar success with all the 3 techniques. ALCA overall did not reach a non-inferiority, so kind of it failed. So IVL RA was equal and ALCA was a little lower in this trial. Then there was a trial of BioAscent ISR, the biolimus coated versus paclitaxial coated. You know, there is a lot. We showed the data of the sirolimus. The paclitaxial has been the gold standard. Biolimus, some data have come. And this is about a 300 patient trial comparing 2 of them. Groups were comparative. Basically, what was the primary endpoint? Again, with the OCT, late lumen loss. This is the angiography, QCA. So key is the late lumen loss was identical in 2 groups, and restenosis rate was 11% angiographic in both the groups. No difference. So basically what it showed, that biolimus coated balloon versus paclitaxial coated balloon has a similar late loss and no difference. Now, this is at the 9-month angiogram. So what happened? So late loss was 0.25 versus 0.27, identical. Now, if you follow them up to 1+ years, there's a little difference we saw. Biolimus coated balloon had a higher numerically, or I can say trended towards higher revascularization or patient-oriented endpoint. Others were not different. So key to me, overall, although there's similar late loss, but clinical endpoint, the biolimus coated balloon failed in terms of the paclitaxial coated balloon in this ISR. So therefore, the next trial was the FAME3. Idea was CABG cost effective or PCI. In the FAME3 for at a 3-year analysis which was presented, basically they went through the whole group who looks into the cost effectiveness with the quality of life attained and so on and so forth. And basically what we know the outcomes for CABG continue to be a dominant strategy compared to the PCI. But then various parameters of the patient comfort, the Euroqol 5 dimension, that's another criteria of patients how they do, and overall you can see they were identical. And same is the quality of life years, also identical both. So if you plot the cost, as you see at 3 years, 24,000 cost in the PCI, 35,000 cost in the CABG group, clearly favors PCI. And so CABG lower cost versus PCI lower cost, it seems to be PCI was a winner in the cost at 3 years. Remember, we had the data on the Berry trial and Freedom and others also. It seems to be that 3 to 5 years PCI remain cheaper compared to CABG. After 5 years, CABG may win little over the PCI. So this is where we are. So next was our, which we call focus review of the month. It was the outcome of follow patients in multivessel disease. Outcome following PCI in patients with multivessel disease who were recommended for but declined coronary artery bypass surgery. So this actually came out after our data, which we have been accumulating for since 2012-2013. So this is basically every year we have the data. The patient with a high syntax score of 22 or multivessel diabetic, particularly they have proximal LAD or mid LAD involvement. We have about 16% of those cases in our interventional every year. So these patients, what happens? They come out of the room, they go outside and then have a discussion by the surgeon. And what happens is about half of them, and it is consistent, about 50% comes back. So they have a PCI later on. So very important observation which we had. We said that, why don't we express this finding to our community, that what is being done at Sinai. So what was basically is 3 group of patients. One, patients who underwent PCI One was the multivessel disease who recommended PCI based on the ACC-HA criteria, which is OC. Second was patients who are eligible and recommended CABG who refused surgery despite heart team recommendation. These were the CABG refusal. And the third group, which is patients deemed ineligible for CABG by the heart team because CABG ineligible, like CVA, COPD, having MI. So those were the third group. So three groups of patients which we looked into it. PCI recommended is a reference group. CABG eligible but refused is CABG refusal group, and CABG ineligible group. So those are the three, and these patients were then followed up to 1 year. Initial recommendation for the PCI based on the criteria are shown here. More importantly, CABG ineligibility shown here with the various regions for it. And what we found, of course, these three groups were totally disparate, because of the characteristics will be different in all three of them. Angiographically as well as the baseline characteristics, CABG refusal and CABG ineligibility all have been pointed out in these two slides, but most important is here. If you see the reference group, composite of death, MI and stroke at 1 year was 4% in the reference group, means OC criteria, patient went for PCI, 4% event rate. Now, if you were sent for CABG, but you declined and went for PCI, the number goes to 7%. And if your CABG, the CABG ineligible, those were means high risk, those become 14. So simple to remember, 4, 8, and 14. So doubling of the output, including the death. 1.5, 3.4, and 9. Very significant difference we saw first time in the literature, showing the CABG ineligible or refusal, I would say. We knew CABG ineligible always will have a high endpoint. But CABG refusal will have high endpoint is the one which we saw and predicted in this study. And subgroup analysis also shown here. So basically, the conclusion by our earlier fellow Anup Koshi, who is right now in Australia and has done quite a bit of work. And actually, in this, Greg Stone also gave a lot of input in terms of publication, output, and so that cardiovascular event rates after PCI were significantly higher in patients with multivessel disease who declined or were eligible for CABG. Our finding provide real-world data to inform shared decision-making discussions. So very important observation. So therefore, our take-home points: OCT-guided versus angio-guided PCI in calcific lesion, 2 thumbs up. Rotablation versus IVL versus laser in calcific lesion, 1 thumbs up, but 2nd thumbs down for the laser. Laser didn't perform as good. Third, biolimus versus paclitaxel balloon for ISR. Overall, it was identical in terms of the late loss, but clinically, we found the lower event rate with the paclitaxel at 1 year compared to biolimus. So I would say it's both negative and positive. And cost effective of the PCI or CABG in multivessel disease management at 3 years, clearly 2 thumbs up in favor of PCI. So traditionally, patients who are high risk for CABG, which are CABG ineligible, have higher MACE rates after PCI because of multiple baseline high comorbid conditions. We knew that. Then second, the recent analysis by our group also identify patients who are more appropriate for CABG over PCI as per the society guidelines recommendation, that is OC, but declined CABG and underwent PCI, to also have higher MACE at 1 year versus patients who are appropriate for PCI based on the criteria. This observation underscores the importance of heart team discussion in complex coronary cases to make the final appropriate revascularization recommendation for the patient. So let me finish our 3 cases because Anu is ready also. One is in the Calcific trial, which one is false? Better MSA in the OCT, lesser stent maloposition. We should do the live IVS. Lesser stent maloposition in OCT, higher major dissection in OCT, similar periprocedural MI between 2 groups, and higher IVL use in the OCT group. The answer basically C. Higher major dissection in the OCT group is false. Everything else is clear. Following statement is correct regarding the results of BioAscend trial comparing BCB versus PCB. In ISR, higher procedural success, higher late loss, higher binary restenosis, higher TLF with BCB versus PCB, and higher POCE and any revascularization of the BCB versus PCB group. Clearly, we found E. So the case is correct. There was higher revascularization, others were identical. Third, the trial of the roller coaster EPIC 22 comparing RA, IVL, and laser, similar use of second plaque modification device in 3 groups, similar calcium fracture in 3 groups, similar MSA between 3 groups. IVL was inferior to RA in terms of stent expansion and similar complication between 3 groups. So IVL was identical to RA in terms of stent expansion. With that note, we stop here and we are ready to see what Anu has to show.
Which is exactly what so many of the viewers have said, waiting for the results.
Good. All right. Anu, tell us, waiting for the results.
That was a 4.0 stent.
Yeah.
Yeah, and we post-dilated with 4.5.
Distal edge looks good. Good
You
lumen.
can show the IVUS, yeah.
Eccentric lumen, but the area is great. And this is the most proximal. Perfect.
Okay, so basically is that minimum lumen is what? So some data have shown that if your lumen is like 10.5, your restenosis rate of the left main will be 0%.
Minimum is 12.
It's throughout. So
It's
minimum
not-
lumen at any area is more than 10.
Where the calcium nodule
It's
was,
more
what
than
did
10.
we get?
Yeah. Not 12, but probably 11.
Yeah, it's a 10 plus.
Yeah.
Good. Show the angiogram now.
Yeah, we showed it, no?
No, angio we did not saw. No,
Yes.
nobody saw the angio.
There, we showed it.
Oh, played? Okay.
Absolutely pristine.
Yep.
Yes. It's a perfect result.
But LED we knocked out again.
Right.
You want to do anything to the LED again or no?
No, I think that cutting balloon
Probably.
dissected it, yeah. I tried to rewire it, we just get into the dissection plane.
So we can try a little bit, but I think we have shown a lot of teaching point, and if everybody is okay, we bring this excellent our seminar to conclusion now.
Samin, just I think it would be appropriate. When I look back at 15 years, I think we have remained academic. There has never been a conflict of interest. Almost all the cases in the last 7 to 8 years have been with OC criteria, and I think Anu's apps have also made a tremendous difference. That seems to be my summary. Great case, so many teaching points. I want to thank the audience for keeping it so interactive. Samin, there is a final question from Dr. Nikhil Jha. He says, Dr. Sharma, please comment on angio FFR and how reliable it is.
Yeah. So I think this is actually coming at the big time, and there are a lot of the association, lot of correlation, and it seems to be a very good device. And there are 3 companies involved at this point, and the trials have shown angio FFR guided intervention is also very predicts subsequent outcome. So I would say the reliability point of view very good. So I think they have mastered the technique, and the Medtronic and clearly few of the companies which are doing a terrific job to bring it to the clinician. So in the past, one of the big issue in America was that there was no reimbursement, but they got the reimbursement code also. Because with the FFR, we have a reimbursement, but now they have the angio FFR, because it will take about 3-4 minutes, or maybe not 3-4, at least 2 minutes to calculate it. But it's a part of the separate reimbursement also now, which has been added, and that will increase the use of angio FFR in our life now.
To our viewers, thank you again. Anu, great demonstration, outstanding skills. We stop here and we'll see you during the next session on July the 16th.
And that will be the CME. Beautiful. Fantastic.